Hello, welcome everyone. This is GU Oncology Now. Today we're speaking with Dr. Scott Tagawa, who's a professor of medicine and urology at Weill Cornell Medicine. He's also an attending physician at York-Presbyterian, Weill Cornell Medical Center. And today we're going to be talking about PSMA PET-CT and its utility in prostate cancer.
We are very excited. We know PSMA has a huge part of the future of advanced prostate cancer, and it's really cool that you're joining us here and to hear from you.
Sure. Happy to be here.
Yep.
Okay. So Dr. Tagawa, can you, for a first question, can you briefly describe what PSMA is and then how it's been utilized clinically in the radiographic detection of prostate cancer?
Sure. So PSMA, or prostate-specific membrane antigen, is a cell surface protein that is present in the kind of normal human body in the prostate, as well as on the luminal surface in several organs, such as the salivary glands, the lacrimal glands, the brushboard of the small intestine, the proximal renal tubules, as well as some ganglion cells. That being said, as a general rule, it is highly overexpressed in prostate cancer, with higher levels of expression generally being associated with increased grade and or metastasis and AR dysregulation. So the more advanced disease, generally speaking, there is more PSMA. That being said, there is PSMA negative disease, and the biggest hazard for that tends to be the kind of ultimately treatment-resistant type of cancer that some people call neuroendocrine prostate cancer. But when there's loss of AR, that's when there's a higher hazard for PSMA negative. But generally speaking, 9 out of 10, there are different ways of saying how often is it PSMA positive or negative. So it depends on what degree, but we'd say roughly 9 in 10 tends to be positive.
Okay, great, thank you. So in 2020, I know that gallium-68 PSMA PET-CT was approved for patients with suspected prostate cancer metastatic disease, or those with rising PSA levels, or basically, in summary, patients that you suspect to have recurrence of disease. Do you foresee any other new indications for these scans in the near future?
So there is another. So there's indications and some clinical utility that's just there, and then there's the FDA. So you mentioned that the kind of on-label FDA approval for there's 2 general FDA-approved agents as of May 2022. There are several different approvals because one has several different versions approved, but those are the 2 on label. With the approval of a therapeutic called lutetium PSMA 617, came a companion diagnostic, so that a different version of that same gallium-68 PSMA 11 PET tracer became another indication. So that is for patient selection for that drug, lutetium PSMA 617, in patients with metastatic castration-resistant prostate cancer. So those are 3 different on-label uses. I think that there are likely to be a lot more uses, whether it has kind of official FDA approval or not. We'll see, and I'm not sure how much it matters. So, we for those of us that treat advanced disease, we can see responses clinically. That's quite rewarding. Their symptoms, and then patients feel better. That's great. That's probably the most important response. You can see PSA go down, and then when there's soft tissue, we can see traditionally scans shrink. CT or MRI kind of get better, but we've been stuck in bones. A bone scan might look brighter or less bright, and that could be good or bad. It's tough to say. So it's only been a small percentage or proportion that we can look at radiographic response I think that is likely to be much higher with PSMA PET. So, the actual ability to look at response, I think, is something that is there. I mentioned in your question, what is PSMA? It's partly related to the AR pathway. So I think we can tell a little bit about the biology of the tumor, what some people call phenotype. So, there's metastatic disease, kind of ignoring PSA levels, by telling us that there is PSMA to a bright or dim degree, it tells us something about the biology of the tumor as well. So I think there are several different utilities in men with advanced disease, and then getting closer to the initial on-label use is what a lot of people talk about as oligometastatic disease. So, there's different definitions, but it just means there's a small number that's visible. It's going to take us a while before we have randomized trials of metastasis-directed therapy or even systemic therapy, et cetera, with hard clinical endpoints. But for those of us that are looking to enroll in clinical trials or, performing what some people call metastasis-directed therapy, I do think that is important to use a sensitive imaging tool in determining, whether or not we're treating most of the disease or not. That might have been not so long ago with a choline PET. Now in that disease state, it's likely that PSMA PET is much more sensitive. So, we want to, if we're going to go after site disease, I think that's another indication that we're learning.
Thank you. Yeah, that's very exciting. There's another scan that you're of course familiar with, Pylarify or Pifluostat, that was also approved shortly after gallium-68, and with similar indications. Could you kind of talk to us about the differences between the two scans and how you use them in your own practice?
So they're identical to me. So talking as a physician practitioner, I think they're identical, basically. So not talking as a researcher, talking as a clinician. Their performance characteristics in terms of sensitivity, specificity, positive, negative predictive value in different disease settings is virtually identical. And I think there might be minor differences between the two, but there's either one of them is so different compared to what we had before. There are many more questions that I would like to answer versus how big a difference is between the two, that I would never discourage research. But I'm much more interested in, if we're looking at other tracers, new tracers with different properties, much more than how good is one compared to the other, taking thousands of patients and one against the other. So whatever is available, basically, hopefully in not too distant future, because there still are some issues in terms of access. That has to do with number of sites that have PSMA PET available and insurance coverage. But hopefully in the not too distant future, it's pretty wide access, and some places are only going to have one. I think that, my advice is to the doctors and to the patients out there, if one's available, take it.